بسم الله الرحمن الرحيم. أنا الدكتور حمدي حسن عمر، أستاذ مساعد كلية الطب، أستاذ مساعد البطنة والكلى في كلية الطب جامعة قناة السويس، وأشتغل طبعا في كاموسكا يونيفرسيتي هوسبيتال فترة طويلة. أشكر الدكتورة مها بحيري على دعوتي، وواضح جدا الوجود الكبير في المؤتمر، وأتمنى النجاح والتوفيق لعين شمس والدكتورة مها. والنهاردة عندي يعني الدكتورة مها عرضت عليا إن أنا يعني أعرض المحاضرة عن thrombotic antiphospholipid antibody syndrome. I will take an overview about thrombotic antiphospholipid antibody syndrome. My objectives here, I will try to do a definition, classification, diagnosis, pathogenesis, and clinical picture, and then I will speak about the treatment. The definition of antiphospholipid antibody syndrome is characterized by venous or arterial thrombosis and or an adverse pregnancy outcome in the presence of persistent laboratory evidence of antiphospholipid antibodies. Antiphospholipid antibody syndrome can be a primary condition or in a setting of an underlying disease as systemic lupus erythematosus or other systemic disease, other autoimmune diseases. The classification, we have three types of antiphospholipid antibody syndrome. The first, which is thrombotic antiphospholipid antibody syndrome, diagnosed by venous or arterial thrombosis and persistent laboratory criteria for antiphospholipid antibodies. I will speak then about what is laboratory criteria. We'll speak about first as a clinical criteria. And then orthostatic antiphospholipid antibody syndrome is described by antiphospholipid antibody syndrome during pregnancy, pregnancy morbidity. Can be several types of pregnancy morbidity. The first one, fetal death after 10 weeks gestation or premature birth due to severe preeclampsia or placental insufficiency. And the third one is multiple embryonic losses before 10 weeks gestation. And also you must have persistent laboratory criteria. Sometimes you have both of them, the thrombotic and the obstetric types, and in this way we refer it as the patient have both thrombotic and obstetric APS. The third one is catastrophic APS, which is a rare syndrome characterized by severe life-threatening form of antiphospholipid antibody syndrome, characterized by thrombotic complications. Usually it is microvascular thrombosis affecting multiple organs that develop simultaneously or over a short period of time, usually within a week. So we should have these criteria. The first one, we must have history of antiphospholipid syndrome and or elevated antiphospholipid antibodies. Third one, we have 3 or more new organ thrombosis which happened within a week. The third one is should be confirmed by biopsy of defining presence of microthrombus. And we should exclude also other causes of multiple organ thrombosis or microthrombosis. We have also this transient antiphospholipid antibody syndrome. Some patient, healthy individuals, 1 to 5% of young adults and up to 12% in old people can have transient antiphospholipid antibody without any clinical features. Its clinical significance is unclear, but follow-up testing is helpful to diagnose or to have predictions will happen in the future. Antiphospholipid syndrome can happen with an autoimmune disease or rheumatic diseases as systemic lupus, erythematosus, scleroderma, psoriatic arthritis, and can happen with several types of infections. As bacterial infection, we have bacterial septicemia, borreliosis, infective endocarditis, post-streptococcal rheumatic fever, and Klebsiella infections. Some viral infection like hepatitis A, B, and C, mumps, HIV, HTLV1, cytomegalovirus, varicella zoster, ABV, adenovirus, parvovirus, and rubella, and some parasitic infections as malaria, pneumocystis, GRC, and vessel leishmaniasis can be associated with antiphospholipid antibodies. We have also some medications, a number of medications have been associated with antiphospholipid antibodies. We have several types, phenytoin, quinidine, some antibiotics, amoxicillin, oral contraceptives, and propranolol also. Some other malignancies, solid tumors, lung, colon, cervix, prostate, kidneys, ovary, and breast, and some hematological malignancies as Hodgkin disease and non-Hodgkin lymphoma, primary myelofibrosis, polycythemia vera, and myeloid and lymphocytic leukemias. So I would like to speak here about what is antiphospholipid antibodies. They are a heterogeneous group of antibodies directed against phospholipid binding proteins. We have many antiphospholipid antibodies, some involved in the criteria and others non-criteria in antiphospholipid antibodies. We have three main antiphospholipid antibodies in the criteria for diagnosis. The first is anticoagulants antibodies, either IgM or IgG. Both of them present in the serum or plasma, can be diagnosed by enzyme-linked immunosorbent assay or ELISA. The other one, which is anti-beta-2 glycoprotein antibodies, also we have IgG or IgM, also in serum or plasma, diagnosed by ELISA testing. The third, which is most of people knowing it, which is usually associated with, commonly associated with systemic lupus, which is lupus anticoagulant. It is a functional testing. It is present only in the plasma, and we have can be diagnosed by three ways or three steps. The first one, which is the detection screening test, like dilute Russell vapor renal time, and also activated partial thromboplastin time. Then we do mixing of the plasma of the patient with other plasmas 1-to-1 to see if it is positive or negative. And the third one, which is if it is prolonged, we add
phospholipids to the mixture, but not with the control plasma, which confirm that the coagulation inhibitor is phospholipid dependent positivity. So we have other antiphospholipid antibodies, which are not involved in the criteria for diagnosis. So the first one is the antiphosphatidylserine antibodies and prothrombin. The second one, domain-specific anti-beta-2-glycoprotein, IgA isotopes, annexin 5, annexin 2, vimentin, cardiolepine complexes, and LBLPA associated with endothelial receptor for protein C. So if you have this positivity for both the clinical features and the antibodies, so we should evaluate this patient and to get accurate diagnosis, the antibody testing should be done within at least 12 weeks to confirm resistance of anticoagulants, anti-beta-glycoprotein, or lupus anticoagulant. And we say that between 12 weeks and 5 years, if we do the test more than 5 years, is not diagnostic, but we should the test should be done within 3 months and 5 years. Involved in the evaluation of this patient, we have thrombosis, is thrombophilia testing. So we have other inherited factors affecting thrombosis, inherited thrombophilias such as factor V ligand mutation, prothrombin G2 or 210A mutation, deficiency factor S, protein S and protein C, and antithrombin. In other neoplasm, myeloproliferative neoplasm, and in paroxysmal nocturnal hemoglobinuria. I will also come in the future in the next slides about the presence of thrombocytopenia in antiphospholipid antibody syndrome. But we should exclude other causes of thrombocytopenia. So unexplained thrombocytopenia and anemia should be evaluated for other potential causes of these abnormalities. So the close relation between antiphospholipid antibody syndrome and systemic lupus erythematosus. So SLE should be evaluated adequately by several testing and handling and treatment and close monitoring. The evaluation of heparin-induced thrombocytopenia, so also other cause of thrombocytopenia, which can misleading the diagnosis also. Here I try to collect this, it's not an obvious slide, but I try to collect it to summarize how to diagnose antiphospholipid antibody syndrome. So we should have at least one clinical criteria and one laboratory criteria. The clinical criteria can be vascular thrombosis, either venous, arterial, or microthrombosis, or pregnancy morbidity. I said also before what is a pregnancy morbidity. Regarding the laboratory criteria, we should have 2 or more occasions, at least 12 weeks, as I said, and within 5 years. Regarding anticoagulants, we should have the titr over 40 PGPL or MPL, or 99th percentile, two occasions, at least 12 weeks apart. And also the same for anti-beta glycoproteins. Sometimes we assess regarding presence of one or two or three. So in patients with more than one laboratory criteria, so there's only one, group 1. And 2A, we have lupus antiviral present alone, 2B anti-cardiolipin antibody present alone, and 2C antibody anti-beta 2 glycoprotein antibody present alone. Also, I would like to say that coexisting inherited or acquired factors for thrombosis are not reasons to exclude patients with APS, but you can categorize them by two groups. The first one, presence of the factors, and the group B is the absence of the risk factors of thrombosis, which everyone know about them, or in the medical field, about the cardiovascular risk factors: hypertension, diabetes, elevated LDL or low HDL, cholesterol, smoking, family history of premature cardiac disease, and obesity, body mass index over 30, and microalbuminuria, and GFR less than 60, other inherited from failures, oral contraceptives, nephrotic syndrome, malignancy, and other acquired factor or risk factors that are associated with thrombosis.
So I would like to speak here about the pathogenesis of antiphospholipid antibodies. So we found that the earliest identified prothrombotic effects of antiphospholipid antibodies were inhibition of natural anticoagulant system, along with other procoagulant and anti-fibrotic properties. Antiphospholipid antibodies induced activation of several types of cells, including multiple procoagulant and pro-inflammatory effects, and activation component are the major driver of the vascular and obstetric complications of antiphospholipid syndrome. Anti-beta 2 glycoprotein I antibodies activate endothelial cells in vitro, leading to expression of tissue factor and adhesion molecules. The antibodies simultaneously downregulate the expression of vasoprotective endothelial nitric oxide synthetase, leading to endothelial dysfunction through transcription factor KLF2 and KLF4. Antiphospholipid antibodies activate the monocytes and cause them to express the tissue factor and other pro-inflammatory cytokines, such as the T1 necrosis factor alpha and IL-1 beta. Monocyte tissue factor expression is increased in patients with SLE and antiphospholipid antibodies, and in patients with primary thrombotic antiphospholipid syndrome. Monocytes from patients with APS also express higher levels of pro-angiogenic cytokine, vascular endothelial growth factor, and its receptor, FLT1, as well as pro-inflammatory mediators such as TLR08 and CD14, and proteins associated with oxidative stress. Also, this paper showing the effect of antiphospholipid antibodies by promoting the effector release of neutrophil extracellular traps, which is one of the factors that inducing the thrombosis in antiphospholipid antibody syndrome. So we found that when you compare the serum and plasma from a patient with antiphospholipid syndrome, elevated level in both of them, serum and plasma, with neutrophil extracellular traps as compared with healthy volunteer. So we found here the Western blot technique. We found that here that neutrophil is present in patients with glycoprotein, beta-2 glycoprotein, and also in the presence of the BBMCs and also in neutrophils. And this slide also showing the expression of CD10, about 37% of CD10 expressing on beta-2 glycoprotein positive patients. The targets of lupus anticoagulant. So due to that they are heterogeneous groups of these anticoagulants, they have multiple mechanisms. So the lupus anticoagulant can be split into two subtypes: the beta-2 glycoprotein and those which target prothrombin. Some lupus anticoagulants act via annexin 5 by blocking the holes in the cells and the annexin shield. The phospholipid bilayer is exposed and vulnerable to clot. So this is the figure showing in the part A how it is in the absence of annexin 5 and antiphospholipid antibodies, that is formation of the coagulation cascades without any interruption. With annexin 5 positive patient, this is the shield over the antiphospholipid bilayer of the cell membrane, so it makes a shield preventing the coagulation cascade. In the presence of antiphospholipid antibody in the C part, we found that this antiphospholipid antibody can delay the coagulation cascade by the antibodies that reduce the access of the coagulation factors to the anionic phospholipids layer. And in the part D, we found that the presence of annexin 5 and antiphospholipid antibodies act either directly or via interaction with protein phospholipid cofactor by disrupting the ability of annexin 5 to cluster in the phospholipid surface, resulting in a net increase of the amount of anionic phospholipid available for promoting coagulation factor reaction. This leads to acceleration of coagulation in vitro and in thrombophilia in vivo. As we said that some patients with antiphospholipid antibodies syndrome can have thrombocytopenia. We found that antiphospholipid antibody bind to beta-2 glycoprotein receptors on platelets, leading to activation of the platelets and aggregation. And thrombocytopenia is present about in 1/3 of patients with antiphospholipid syndrome due to binding and activation of the platelets. Antiphospholipid antibody syndrome is like other syndrome as thrombotic thrombocytopenic purpura, DIC, heparin-induced thrombocytopenia, maternal hemoglobinuria has prothrombotic effect in the setting of thrombocytopenia. Here, this paper is abstract done in Japan, showing that thrombocytopenia in primary antiphospholipid syndrome is related to arterial thrombosis. So they found that in this figure that the patient with thrombocytopenia have more thrombosis than the others without thrombocytopenia. So they found that higher risk of arterial thrombosis and in the setting of thrombocytopenia and antiphospholipid antibody syndrome, the thrombosis is more likely to happen than bleeding. As we said, also the role of complement and the gene mutations on the thrombosis and antiphospholipid antibody syndrome and the catastrophic antiphospholipid antibody syndrome. So we have both gene mutations for inhibitory genes and the activating genes mentioned here, and this balance between the both genes and this balance leading to the disruption, this balance leading to activation of the complement, leading to disseminated thrombosis either in the setting of antiphospholipid syndrome or in the setting of catastrophic antiphospholipid syndrome. Here, the Ham test positive, which is present in patients with antiphospholipid antibody syndrome, and is a marker for and is used here to show that it is more likely to happen with thrombosis. And we found that here in patients with SLE and patients with antiphospholipid syndrome and patients with catastrophic antiphospholipid syndrome, about 85% are positive. And also other parts of this slide showing with the single and recurrent and triple and recurrent thrombosis with this Ham test, positive Ham test. And also the positive Ham test more in the triple positive antiphospholipid antibodies. Here also some of the gene mutations present like the mutation here here NH mutations, ACH also, and the CD5 antibodies present also in these slides. So, time a little bit. So, مش عايز انقل بتاع.
دبل كليك يا دكتور علاء.
Yeah, now it's working. Here's a next slide showing the complement activation thrombosis and different genes here as complement activation, and it's associated with some activation CD4B and CD3B. As mentioned, LHR, LHRB, LHRC, LHRB mutations. So I'd like to move to the clinical features. So mainly these are thrombotic events, either DVT, pulmonary embolism, stroke, superficial thrombophlebitis, transient ischemic attacks. We have lividoreticularis, Sneddon syndrome with widespread lividoreticularis in association with stroke, cognitive defects happened with antiphospholipid syndrome due to maybe minor strokes. And also a thrombocytopenia with a risk of thrombosis. We have also non-thrombotic manifestations, either neurologic. We have chorea, longitudinal myelitis, hematologic thrombocytopenia, and cardiac and some valvular inflammations. So in pregnancy losses, early pregnancy, the first trimester losses are typically attributed to direct inhibitory effect of antiphospholipid on trophoblast viability, proliferation, and invasion. These derangement prevent proper anchorage of the placenta to maternal decidua, resulting in first trimester miscarriage. Late fetal death may be due to fetal growth restriction, preeclampsia, so it can happen due to consequence of both trophoblast dysfunction and direct inflammatory effect of antiphospholipid antibody and complement. We will not also miss the hair COVID with antiphospholipid antibodies. So we found that many studies showing that the presence of thrombosis with COVID-19. So functional assays such as Lupus anticoagulant must be interpreted with caution in critical patients because they can be transient positive due to infection or high level of C-reactive protein and cause this Lupus anticoagulant phenomenon. So we are a nephrologist, so we should speak about the real complications of antiphospholipid antibody syndrome. Part of patients, primary antiphospholipid antibody syndrome, we have effect of on the glomerular capillaries or other renal diseases. Both arteries and veins of all sizes can be affected. The disease can be silent or may produce acute or chronic renal failure with proteinuria and hypertension. So it can be presented with hypertension, renal vein thrombosis, or renal artery stenosis or thrombosis, ischemic nephropathy, antiphospholipid antibody syndrome nephropathy can be acute, while thrombotic microangiopathy, chronic specific intrarenal vasculopathy, arteriosclerosis, intimal hyperplasia, tubular thyroidization, cortical atrophy. We have also glomerulitis reported antiphospholipid antibody syndrome. Can be primary membranous nephropathy, CEC, glomerulopathy, minimal change disease, FHGS, and secondary with lupus nephritis from class 1 to 6. Renal function and cortical necrosis can happen also. Vascular active thrombosis in hemodialysis patient can have it frequent on this patient. Renal allograft complication, renal vein thrombosis, also renal artery thrombosis, relapse of antiphospholipid antibody syndrome of allograft, pregnancy-related forced preeclampsia can happen. Here, some pathological features. The A part, we have platelet thrombi stained with anti-CD61 antibodies, legal karyotype marker, and in the part B, GPM duplication, unwinding of subendothelial space, and C part arterial TMA, and D part arteriosclerosis in chronic form of antiphospholipid syndrome. Antiphospholipid antibody syndrome antibodies and SLE. So in antiphospholipid syndrome, about 50% have systemic lupus erythematosus or other autoimmune disease. When happened, it is a secondary antiphospholipid syndrome. And in systemic lupus erythematosus, patient with SLE can have 30 to 40% of patients will have antiphospholipid antibodies. So this slide showing the association of antiphospholipid antibodies with the clinical activity of lupus nephritis. We suggest that this study is suggesting that presence of antiphospholipid antibody associated with clinical activity and renal pathological activity with lupus nephritis. And in this slide, the same paper showing that we have the 3 antibodies present in about 48% of the patients with lupus, and with a lesser degrees if it is 1 or 2 or 3 parts. So the treatment of antiphospholipid antibody syndrome, we have some treatments which are using nowadays. As a preventive treatment in patients with SLE who didn't have any thrombotic manifestation, didn't have antiphospholipid antibody syndrome, but they have only SLE. So suggesting low-dose aspirin. So it is more preventive for the arterial thrombosis, not for the renal thrombosis. And also hydroxychloroquine, which has antiplatelet role and reduce antiphospholipid antibody titers. Prophylactic in patients with antiphospholipid antibody syndrome, vitamin D, reduce activation of tissue factor by antiphospholipid antibodies. It can reduce the risk of thrombosis in patients with prostate cancer, so it is showing some prophylactic effect in other diseases. Statins can reduce some inflammatory mediators, and tissue factor statins have shown to have antithrombotic effect. So thrombosis treatment. So we have low-dose aspirin is recommended for non-pregnant women with a history of obstetric antiphospholipid syndrome only. And in patients with antiphospholipid syndrome and faced unprovoked venous thrombosis should receive long-term treatment with the vitamin K antagonist with target INR 2 to 3 fold. In patients with antiphospholipid syndrome with first arterial thrombosis, treatment with vitamin K antagonist with INR 2 to 3 or maybe up to 3 to 4 is recommended. We should consider the bleeding thrombosis risk. The oral anticoagulant, new oral anticoagulant shouldn't be used with antiphospholipid syndrome, and I will come to a study about that next. The patient with recurrent arterial or venous thrombosis, despite adequate treatment, should have adding low-dose aspirin 50 to 100% and increase the INR target to 3 to 4 folds. Or maybe switching to low molecular weight heparin may be considered. In women with prior obstetric antiphospholipid syndrome, combination with low-dose aspirin or prophylactic dose low molecular weight heparin during pregnancy is recommended. In patients with recurrent pregnancy complications, as preeclampsia, eclampsia, or placenta insufficiency, but no history of venous or arterial thrombosis, increase of low molecular weight heparin to therapeutic dose, and the addition of hydroxychloroquine, and maybe sometimes can use low dose prednisolone in the first trimester can be used. Here, some studies, some new agents is not totally new, but it is used with process new now as rituximab. It showed it is effective in the treatment of catastrophic antiphospholipid syndrome. So we should have the diagnosis of catastrophic antiphospholipid syndrome to use rituximab. Also, in catastrophic antiphospholipid syndrome, methylprednisolone pulse can be used. Plasmapheresis also can be used. So it is all of them showed some effect, but not 100% effect. That is catastrophic and is life-saving. So we come here to refractory catastrophic antiphospholipid syndrome. Can be responded or not. So this is to eculizumab. So it's a very expensive drug which is used with other hematocritic syndromes or other PNH, but here it can be used, but it didn't show great effect. But it is used when we don't have any hope for success or to save this patient. So can be used successfully sometimes to save a patient in which thrombocytopenia and microangiopathic features are the main manifestations. So I would like to show here that the treatment with rivaroxaban or other new oral anticoagulant are not superior as warfarin in a patient with systemic lupus and with thrombosis. So this patient get DVT first and received rivaroxaban, which we found that GFR is going down and also platelets is low. But when we these people added the warfarin, so we found that GFR a little bit increased and the platelet also has been increased. So a lot of groups, a lot of researchers didn't recommend the using of oral anticoagulant in comparison to the new oral anticoagulant in comparison with the warfarin. Thank you very much for your attention. I hope I have get an overview about the thrombotic antiphospholipid antibody syndrome. Thank you very much.